You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
We were just talking about oozing knees and yeah, I don't even know.
A little barnyard banter.
Yeah, we were just patients coming in with a wound, which is not a typical. I don't think that's. Do you have a case about a wound today when you're talking about interesting cases? Is that what you were talking
That'll
about?
actually be my third one.
Shark bites.
That'll be like my third, basically like fresh wound in the last week. Because I had that one girl from soccer that got absolutely obliterated.
Yep.
2 days ago, I saw a lady that she was playing with her kids and like jumped. And when she jumped, her knee smoked the bottom of a table. So it's like swelled above. So I guess we're going to do.
2 feet down. How did she jump and hit the bottom of the table?
She's 7'4", Alex.
Small table. Dude, we have little kid tables at our house. You can get all sorts of stuff. Which updated the Beard household. So we were going to put built-ins in the playroom. So we sat there. I dumped all the kids' toys out yesterday, which they actually play with them then because they can't see them. So here's a hot tip if you're a parent. If you feel like your kids are always bugging you and they're just daddy, 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 do this, do that, just dump all their toys out. And then they just get lost in the mix and you won't find them for a couple hours and your house is destroyed. But they literally didn't say a peep for about 3 hours. And I go in there and it just looks like, a nuclear bomb of toys went off. Now we're in the organizing phase. So
How good do you think they'd be at 52 card pickup?
we find out every night because they have matching cards and
Every
slapjack and Old Maid and animal guessing game cards. And those just literally.
Old Maid.
And now Maddox is trying to learn to shuffle.
Yeah,
Shuffle. We also played the matching game or the memory game the other day. All of the cards were right next to each other from the previous game that Maddox was going. And then she'd pick one and she'd just pick the card next to it. Oh, I won. And then the rule is you get to keep going. And she basically just housed me. And I was like, you're a cheater. Straight up cheater. Okay. Week in review. Is this 42?
42.
Updates. Big update. I'm going to play taps. I'll play it in the background here on trumpet. Dun, dun, dun. That sounded either like Darth Vader or taps. I don't know which one. But Dr. Daniel is no more. He's still alive. He just left practice. Looks like his practice looks pretty nice.
Yeah.
Saw the post. So he has been with us. It would have been 5 years this year. And then from the beginning, knew we openers no practice and finally pulled the trigger on that. So he's in downtown Birmingham. So if you're a local listening and don't want to drive out here, he's down there. So happy for him. And I'm sure he'll do pretty well. And yeah, I'm sure he'll still be around. Nobody does anything fun education-wise in Alabama except us. So we'll see him again. What else? We were just talking about Alex's oozing knee and sicknesses. So Seth had the stomach flu, or assuming flu B first.
Smoked.
I didn't. That was Monday.
Yep.
I was literally in a room working on somebody, which is the case I'm going to talk about, which is kind of funny. Working in the room, and I break out into a sweat, and I didn't really feel bad. I just broke out a sweat. I was like, "Oh, that's weird." Like, took my sweatshirt off. 5 minutes later, I walk out into our kitchen area, and I look at Bridget. She goes, "What's up?" I was like, "I don't feel good." She goes, "You don't look good." And I barely made it home before my body exploded into fluids.
That was the same day of the last podcast because we recorded the podcast and you got sick, and then that's when I got the upper respiratory.
And then Alex was out the next day. Yeah, so it's been fun. And our intern's out with COVID indefinitely.
He's been smoked for like a week and a half.
Yeah. Yeah. So
he wasn't in starting like Wednesday of last week.
Yeah.
Oh, yeah. It's been.
He might have to get a bubble or some sort of.
This is the second week that he's
biodome to live in. So what's the lesson here? Don't have kids. No, actually, I don't think this came from a kid's. Actually, when you have a stomach ailment, whatever it is, food, because the other interesting thing is we had eaten at a local restaurant, very nice restaurant, Tuesday. So while I'm laying around Friday, in between puking and all that stuff, the owner of the restaurant's texted me. I was like, I don't want to talk to anybody. I'm puking. He goes, well, no, that's what I'm calling. So people had gotten sick from eating shrimp, which I had ate that night. So it's just all this stuff going on. But whether you had food poisoning, some sort of GI distress, I would say there's 3 things you could do after the fact to kind of restore order, if you want to call it that, because some people, can have all sorts of lasting effects. The first one would be while the thing is going on, a lot of people obviously use things like Pepto-Bismol and stuff like that. But I would say charcoal, so like a binding charcoal of some sort. all sorts of brands. You could also, I guess, take ash out of your fireplace and, just store it down or piece of
mouthful in the fireplace.
Dude, you ever watch Naked and Afraid? Just take a little charred piece of wood in the bottom, scrape that thing up, brush their teeth, eat some if they got giardia. Doing great.
I think I'll just take fluid loss.
So charcoal is a binder. Colostrum, which colostrum you want to take first thing in the morning on an empty stomach. That's the best way it's going to act. You could also have a powder form to mix into like smoothies and yogurt and stuff. Prebiotics, I guess. Probiotics, yeah. The last one would be glutamine. So glutamine is high on the list for people with leaky gut, and I get that leaky gut isn't hand in hand with like general GI distress, flu. You're basically just trying to allow your gut lining to heal after getting absolutely destroyed, but also the fluid gradient gets. So I was supposed to run that 50K that we talked about last time, which was that Saturday. Got sick Thursday, and in my head, even as I'm like super sick, I was like, I should be fine by Saturday. Like I'll bounce back, and I could barely stand on Saturday still.
Yeah, you were out here with the rubber tiles.
They were putting a rubber flooring in on Saturday around 2 or 3 p.m. And I put a couple tiles down, just sweat and felt, terrible. Absolutely terrible. So we've all been sick. Did you do anything fancy biohacker? No.
Let me tell you.
Besides, no, he just slept.
He told us what he ate last night. So I wouldn't call it a biohacker's diet. But basically, Seth and I have some sort of tapeworm post-flu because we can't gain the weight back, and we're eating a tremendous amount of food.
Mine was ginger ale, some Jello, and some saltines.
Just a standard hospital visit for Seth.
I felt like I was in it in my room.
Oh,
I'm like laying in my bed, feeling like I could cry right now. I feel so miserable.
So I would throw up, sweat profusely while I was throwing up. Maybe have to do something else in between throwing up. And then lay in bed and literally couldn't stop violently shaking.
Oof.
And then you just do that over again.
It felt like my cortisol was through the roof.
Yeah.
But I know that there was nothing else happening in my body except just water going in and out.
Yeah. I had zero fluid.
You guys had it longer than... So I had the
2
upper
days,
respiratory infection. Then a week after I got the stomach bug for like 24 hours.
Yeah.
Only didn't have the throwing up, which was...
So
fine
basically,
by me.
If you don't want to have to get a flu shot or any kind of booster, just come to the farm. You're going to get sick.
Yeah. But I will attest to the colostrum and glutamine. Mm-hmm. So I did because basically just got what's going to happen in the next couple of days by watching whatever happened to you. Because it was, you're going to the bathroom all the time and then not at all. And did 2-day fast and then colostrum, glutamine. And that's been super helpful. When I got sick a couple months ago, like upper respiratory stuff, and everybody's like, why do they get sick so much? I've got 2 little kids and we're around patients all day who also sick. So it's like, it's a hard thing not to get something. I read a bunch of stuff on fasting because I was just really sick with like upper respiratory stuff. I was like, this sucks. I'm over it. So most of the research shows that you shouldn't fast when you're sick. Like it's too much of a stress on the body. Right. And it's there's stuff on both sides when you look at it. But then fasting after the fact can help with that was after.
Right, mitophagy and autophagy and kind of cleaning up some of maybe the viral capsid stuff and things like that. So, but what's the old wives' tale? Feed a fever, starve a cold. I don't know what it is. Which is not true.
No.
Because there's a starve something in there. But
the only other thing that I did...
I couldn't eat anything when I was sick, though.
No.
That wouldn't happen. So I was fasting without trying to.
It was more so that, like, I knew if I tried to eat something, it was going to be...
I woke up... I told you guys I woke up Saturday and chugged a mason jar of Element. I thought I was going to poltergeist that stuff or whatever all over.
Spindrift is what saved me. Because
yeah,
it was something... I don't know. I guess that's kind of how I feel about ginger ale. Like the pure water, it just felt so heavy on my stomach, but the carbonation made it feel way better. Sloan
went and got the tiny cans of Coke Zero and Sprite, which she's a Coke Zero weirdo because of trail running, because it's the healthiest sport in the world. So she got Sprite, and I was like, I don't want any of that crap. Like I don't drink. And I'm telling you what, Sprite on some ice, game changer. Late that Friday, I was like, okay. Here I am. So enough about the sickness. So some tips on lower GI distress, respiratory stuff.
Sauna was one that I did. Yeah. I did that not during the GI stuff. Now, I didn't have a fever. Yeah. I was going to make a video about it, but basically, if you're having upper respiratory issues, a little cold, sore throat, congestion, sauna can be helpful, but if you have a fever, not a good idea.
Yeah, you're just competing with the fever. Anything else on just kind of general update stuff? We worked the Wine 10K this past weekend, which was really good.
I did a race.
Seth
Yep.
did a duathlon.
Yeah, that was cool.
Yeah.
I got 3rd or 4th overall. I know that's like a questionable, like, did you get 3rd
I
or
don't
4th?
really know.
Because so
Did they not post results after?
they only posted age group.
So there's no like web, like there's not an ultra
Mm-mm.
sign up thing for this type of stuff.
Nope. So they just did like age group awards afterwards. And so I was first out of transition from the first run. And then I got passed by 2 guys, maybe 3 on the bike. But I'm also not sure if I got passed by
Did you catch anybody on the run on the second time?
Yeah, I caught like 5 or 6 people on the second run, but there's also a 6, a 12, and a 17-mile bike.
I was going to ask. I was
There's
like,
different
well,
options.
I got
So, like,
because I was like, wait a minute, how'd you get passed by them? Yeah.
So we started first as a 17-mile group, and then they waited like 5 minutes and sent the rest of everybody.
Gotcha.
So then when I came back in transition, there's like 5 or 6 people all around me, like leaving. So I wasn't, I didn't know. I recognized some of them that had not passed me, but at the same time, they kind of like smoked past me on the bike, but I still had to keep going, like another like 5 miles and come back. So I don't know.
Yeah.
But I got first age group. I
Pretty
guess.
solid post.
Yeah, I'll take
Summit-
it. I
Summit
mean,
bar.
it was a 17-mile bike and a little over 1,000 feet, and I did the same amount of, I guess, like speed. I don't really have a power meter, but I maintained the same speed as I did from last summer on a course that had, this course had twice as much elevation as the other one.
And it was shorter.
And it was
Last
shorter, so I'll take it.
And then again, when's the Ironman? Half Ironman?
May 10th.
That's next, right?
Yes. Well, yeah.
You got next
There's a April 19th. The Tri Club is going to do like a practice try, so I'll probably do it, which will probably be a sprint.
Yeah.
But yeah, I'm looking at hotels this week.
I'm still on the fence about Xterra. I don't know. I have to decide soon.
Yeah.
We'll be working it.
We'll be there.
Yeah, I'll be there for sure. I'm just trying to decide if I want to race it or not. I don't know. We'll see. If they do the kids try, I probably won't. So I can help with Maddox and stuff. But the schedule keeps changing. So that's supposed to be Friday, but now it might be Saturday. If it's Saturday, I'm for sure not doing it. So we'll find out. But in terms of races that we're working, besides Xterra, so Rump Shaker 5K 2 weeks from now. So not
2 weekends, yeah.
For 22nd.
Yeah, 2 weekends from now, the 22nd at Regents Field. No, I don't think we've ever worked that before.
Yeah. My family's run it before.
Same weekend. So we have DNSA in Nashville coming up in 3 weeks. So the first weekend of April. Trying to think of anything new. So that's CE'd for Alabama and Tennessee, which is a pretty big deal. I haven't looked into, so I can't say this unequivocally, but I don't think any other DNS course has ever been CE'd. They were traditionally very hard to get CE'd because of just what you had to apply for and the lack of information of DNS. But I think as DNS has gotten bigger, it's gotten a little easier to push through a school. But that's with Brett Winchester. Audra Lance and myself will be putting that on, which we're both DNS practitioners. So we'll probably be helping a little bit. We have some celebrity cases or examples that we'll be using. And then some extremely fun stuff. If you know what the listening room is in Nashville, we have a pocket of tickets for that Saturday night. I guess I should have probably looked at where we're eating dinner on Friday and stuff, but fun stuff. So still time to register for that. And just check out upcoming seminars, and you can find that same weekend. Alex will be at the Oak Mountain Running Retreat that's being put on by Finish Line Catering. And that their only company now, or does he have like multiples going? Is that the thing? So Jonathan Croy, Annie Tate, Finish Line Catering is their main company, I think. But also, did you see the new event that they are doing with Xterra in like September? In Trail Fest or something like that, which is an Xterra event. So it's an Xterra trail running event, 35 and 15K or something, which are the world championship distances now. So I'm assuming that means you can qualify for the race that I did years ago in Kailua if it's still there. I don't know. I think it's actually in Vermont now.
That's a tough switch.
Yeah. So the time of year it is. So it's still in December. I'm pretty sure. I could be wrong. So if somebody wants to look into that, but
Courses aligned with maple syrup, though, maybe.
I'm there.
I'll look into it and kind of see. Give us a rundown on Ethan Strand and any track and field stuff. I'm going to look up some stuff on the Xterra and update.
Yeah, we need Ethan to race some more, so we have some more stats. But no, he had the ACC championships for this past weekend, and he went up in distance, ran the 5K, which. He's a fast guy. He can run a good 5K. We just normally see him in the 1500 or the 3K or the DMR. But wins the 5K in a new ACC meet record, 13 minutes, 26 seconds, which honestly, the most impressive part of the race was the fact that he and Gary Martin, Virginia, broke away with, I don't know, a mile to go, slowly started breaking away from the pack. And then in a matter of 150 meters, he put 4 seconds on second place. So he closed his last 200 meters in 26 low, and he let up before the line. It's just, yeah, it's cool to see, especially a guy from Birmingham winning at high stages like that, and then to have the gears that he has to finish races that way. So we'll have NCAA championships next weekend, more conference meets this weekend, but he'll be running the 3K and then the DMR. So yeah.
All right. I'm looking there. This is not that I have to be the Xterra salesperson, but it looks like it's in the UK.
Still speaking of like the NCAAs, they kind of put out some posts of like what it looked like 10 years ago. Right. So they did like a 2015. So like, I guess that's when like
starting college.
You were starting college. I was going into my senior year of high school, and so the fastest time that got in like the 3K, like 10 years ago, wouldn't have made it this year.
Yeah.
On qualifying times. And it was pretty much like that across the entire board for like 5K, 3K mile, even like some of your sprint events, like the fastest guy I think would have been like towards the bottom. So it's kind of cool to see like how fast or how far like we've progressed 10 years ago. Cause I mean, you see these times and you're like, okay, that's pretty impressive. And then it's kind of like that, the Roger Bannister effect, where it's like people start just like clicking off some times, because 7:36 would have been again NCAA leading, and that's what Gary Martin did for the 3K this past weekend for ACCs, which is a new meet record, which of course would be a meet record because it would have been the NCAA collegiate all-time record. And then it's like he's maybe like eighth or ninth going into the event.
8th or 9th on the all-time list.
So he's like 8th or 9th in the NCAA right now after, which is crazy.
Yeah.
And that all happened in this last year.
Yeah, 10 years ago, you would have had 10 to 12 years ago, big guy for the U.S. in the 5K would have been Galen Rupp. And I remember in indoor watching him run like 13:01, and that was a new American record. And since then, this season, there were 3 collegiates that broke 13 in the indoor 5K, and now new American record 12:44.
Yeah,
it's cool. Cool time to be following running. I believe our boy Bugaj called it the golden era of running.
Yeah. Shout out to Bugaj. Switching sports a little bit. I know you guys aren't huge golf fans, but in the golf world, all of the people, I know you guys know what the Live Tour is.
Yeah.
So almost, not all, but a lot of people that went to the Live Tour come back to PGA, which is kind of crazy.
Right.
So world majors, right? So you got the PGA Championship, the Open Championship, the Masters, and then the Players Championship. If you lose standing, right? So some people have exemptions, like lifetime. Like if you ever won the Masters, you get the Masters forever. If you've gotten to the Masters, I might be speaking wrong here. I think you get an exemption for the next 5 years, right? And then if you place in the top 10, it changes up. So there's sponsor exemptions to get into tournaments automatically, right? For winning something. And so you have all these ways to get in, but if you lose standing, so you haven't played in these events on the PGA, you can't get into the majors. And then if you can't get into the majors, you lose FedEx standing, and the FedEx Cup is huge points. So the story got popular with like John Rahm, because there was an article that came out that said John Rahm falls out of the top, I want to say 50 or something for the first time ever. It's not because he sucks, it's because he's not playing events. But anyways, that's leading a lot of these people to come back to the PGA. So it's kind of like the PGA and Jay Monahan, I think they have a new CEO now. So these guys are coming back. So it's kind of cool because the Masters is coming up, and the Masters is one of the bigger events. And they're, what was the event going on right now? The Arnold Palmer Invitation. A bunch of the bigger players didn't get invited this year. And there was a big, like Jordan Spieth, Ricky Fowler, I think Justin Thomas, like none of them got invited, which none of them are on the Live Tour. So there's all this weird stuff going on. But coming into the Masters, it's just one of the bigger events that, is highlighted. So it'll be interesting to see, like, because they don't announce the field. They have till Wednesday. I want to say Wednesday the 5th or something of April, because the week, and I think it was when they announced the field. So like players can get back to them and stuff like that. Or is it something like that? The field is announced a week and a half before or something like that. So anyways, if you're a golf nerd, kind of like I am, and pay attention to it, I'm really interested to see who's going to be in the Masters, and then like after the Masters occurs, or if people announce it before, of who comes back full time to the PGA, and then what happens with that whole deal. But yeah, I'm just kind of a golf nerd that's paid attention to it because it's one of the few sports that I like actually know people that play or are involved with it, so it's kind of fun. And if you're also a golf nerd, check out the new season of Full Swing on Netflix because just kind of behind the scenes. All right, let's move on. Other updates, events, sports happenings, things you want to nerd out on. Speaking of nerd now, let's move over to some articles. Well, actually, podcasts and articles. The update on it came out, I want to say early last week. Dr. Keith Barr out of UC Davis was on my podcast. I don't know, summer of last year, late summer. And he was on Tim Ferriss's podcast just last week, which is really cool to just see somebody that I've followed his work, used his work, and seminars and classes I've taught for years. Is the leading, in my opinion, authority on tissue regeneration, tendinopathy. Was a strength conditioning coach before he got his PhD. So I think also the thing that sets Keith Barr apart is like the applicability of what he's using or researching. So a lot of people do research, it's good information, and then they don't have the next step from the research side, and it's kind of up to you to interpret and weaponize. I mean, he literally can break it down and just be like, oh yeah, we do this, right? And like, Tim Ferriss was just asking him about lateral epicondylitis the whole time that he has himself from climbing. And like Keith Barr just went through like, yeah, I do this. So it was like, he's not a clinician, but speaking from the research side, sometimes it chains people, but he's like, oh no, it can just be this easy. Now, we know in our world, when somebody says they have lateral elbow pain, that doesn't always mean, it's a tendon issue or it needs tendon loading. So there's that kind of side of it that I wish, then I would have been like, oh, I'm going to fanboy completely if Keith Barr would have been like, well, it always is good to get a workup because it might not be your tendon just because you have pain at your, lateral epicondyle. That wasn't talked about. So that was my only knock. But we talked in here about 3 really cool components that I thought were good for clinicians to know. So the first one that he talked about was the research on what he termed as pithing, which is basically just needling. That when you're needling a tendon or a ligament or a tissue, the thought for a long time was that we're going to go in and create a pro-inflammatory cascade by basically needling the area that's damaged. And he goes, well, it's probably less of that from what we're seeing in the research. And it's you're needling the healthy areas of a tendon in particular. And then when you go to load the tendon, you have a more uniform loading strategy because you don't have kind of this stiffened, harder area to load. Everything is kind of damaged a little bit. And then as we go into the isometrics, whatever loading protocol we're going into, again, more uniform load. So I thought that was different than what we would take into account. I think the difference there is acute versus chronic. That makes sense for acute for me. If you have chronic, I don't know if that makes sense from both. It would help to have a pro-inflammatory, and you have a lot more stiffness in the damaged area of a tendon. I don't know. I would like to ask him that question, but what were the other 2? Oh, the fact that like Henderson's initial, Henderson was a researcher, one of the researchers that came up with the initial like protocol for tendinopathies, where it was isometric, eccentric, concentric, plyometric, or ballistic, right? Which was supposed to be safe and just kind of the tried and true. And he was like, Keith Barr was kind of saying the eccentric loading thing of causing more muscle damage, which causes more cross-linking and, speeds up rehab is not true. He goes, it's just full range of motion. Weightlifting produces the same results. You have to have isometrics for a tendinopathy because of how the tendon loads dynamically, and to get a stiff area that's damaged to load versus a healthy area, you have to have a longer duration, basically static load. But he goes, when it gets into the tendon is on the back end of a chronic injury, or if you have like a muscle strain or something, it's just full range of motion. So that's also something I think is still probably talked about. I'm trying to think what the last one was. I didn't expect to talk about this, but let me see my notes real quick. Oh yeah, I thought this was a really big one for clinicians. If you're listening to this, so angiotensin 1 inhibitors, or which is your group of like sartan drugs by name, right? So I don't know exactly what the avrosartan or whatever, the multiples that are blood pressure drugs. So a huge swath of people in the U.S. for sure on these drugs, right? And this is one of the drugs that they tend to put people on, even if you're borderline. 145 over 90, things like that. So I always talk about in the courses I teach, which I'm going to do a small tendinopathy online course, probably like 3-4 hours, which will be coming out here in a couple months. But I always tell people to ask in their paperwork, And then ask in the history, have you taken a fluoroquinolone in the past 2 to 3 months, even maybe 6 months? Fluoroquinolones are broad spectrum antibiotics that are gnarly on soft tissue regeneration. And the typical ones are things like Levaquin and Cipro. Cipro is very common to give to people, especially from the US traveling overseas, again, a broad spectrum guard against things like malaria and Giardia and things like that. So with taking a fluoroquinolone, you have about a 3.5 time greater risk of rupturing a tendon or a soft tissue injury. When you take an AT or an angiotensin 1 inhibitor, you have 7.5 time greater chance. So that's a huge leap above what we're asking, which I didn't even know that. But then the amount of people that are on that AT1 drug versus like that have taken a fluoroquinolone is like through the roof. And it's a chronic, like you're taking it all of the time. So that's a huge thing to ask, because I mean, I've literally had people like, I know like the fluoroquinolone caused the tendinopathy. And then you're like, well, this is going to be a tough thing to treat, pithing and isometrically loading and all these things, because there's a physiologic reason or mechanism behind this thing. So those 3 points from the Keith Barr episode, I highly encourage you to go listen to it. Ton of good points. For your clinician, you're going to nerd out. And if you're, a layperson patient, very practical things you can do for your own injuries and how you think about, a lot of different things. And, one thing for the layperson to hear is, the counter arguments of things like rice and bracing and immobilization, which I don't need to harp to the clinicians too that are listening to this, but really good points on that. So that was a podcast. Now the articles I wanted to talk about were, the first one is the title is Protein Quantity and Source Fasting Mimicking Diets, which this is, let's bring this up. This is out of, I think Walter Longo is out of USC, positive on that. But basically heard him talking, was he on the Rich Roll podcast? And he was talking about how he thinks that we've thought about protein intake wrong. And what he meant by that is like, we're just talking about protein as like, it's a protein, it's a macro. And he goes, protein's amino acids. And there's different amino acid profiles in all different foods, right? Keith Barr would hammer on this because taking collagen is very different than taking whey protein in terms of how that amino acid profile from collagen helps a tendon basically reorganize its collagen structure when you go through appropriate loading, because of the amount of leucine and proline in it that doesn't exist in whey protein, or not the amounts that exist in whey protein. But what Longo was talking about in this article and on the Rich Roll podcast, I thought was interesting, which I've thought for a long time. And I've heard people like Lane Norton beat this idea up. And I get, again, the practicality of telling people get these specific amino acids versus eat 1.2 kilogram or 1.2 grams of protein per, pound of body weight or whatever it is. So Longo's like, yeah, we see better longevity outcomes from a protein restricted diet across the board. So that flies in the face of a lot of the current health stuff that you hear, right? Is like, hey, get your protein. And this comes from both, these are surveyed, right, or longitudinal studies from humans, but also a lot of animal studies, a lot of rat and mouse models. And he goes, and then what's interesting is that you see it's the amino acids. So the variety of amino acids is what actually creates like a better, diet for general health. And he goes, so it's not necessarily that if somebody eats all meat, that's bad. It would be the same if somebody got all of their protein from just legumes, right? It's the variety of the amino acids, which makes sense. Amino acids are building blocks. And if you have too much of one amino acid and not enough of the other in any one meal, it can shut off some of the mechanisms, right? What can occur, especially like recovery, that's where like whey protein is, a lot of people talk about it's not ideal for a recovery standpoint based on the amino acid profile in it. It's where people get into things where we thought branch chain amino acids were good. And then we saw there was a huge insulin spike with those. And then essential amino acids became the thing. What he was saying is basically just a plant-based, because that's what his studies have found, right? A plant-based diet that is lower on protein intake, that has a more varied amino acid profile, is the best thing you could do for human health in the long term, which again flies in the face of a carnivore diet, eat meat only, no vegetables, because the protein, the amino acid profile in a piece of meat is the same across the board. Varies a little bit in animals. Like there's more, I know in particular in like chicken, there's way more tyrosine. And, then there's also with certain farming practices, those amino acids maybe get a little deranged. I just thought it was very interesting because, again, Walter Longo is the, if we got Keith Barr, the tendinopathy domain expert, Walter Longo on fasting, but fasting mimicking diet. I mean, that's what he's the one that basically coined that term, but it was Brandhorst and Longo on that study. And I'll put links to these studies in the podcast or the show notes. And that was from 2019. So, and go listen to the Rich Roll podcast too, because that's, again, they're talking to the general public. The other article, and if you guys have, any input on these, let me know. The other article, and I don't know why I started looking into this. I just every once in a while, my like hippie crunchy self comes out, and I wanted a pair of like wired headphones to use for editing in here. And I was just looking for like cheap, like earbud ones that are wired. And then I was like, what can I find on the whole, magnetic frequency stuff and EMF? Is it actually a deleterious, health thing, which I don't know if you saw RFK's supposedly going after 5G now and all this stuff too. So, yeah. There are a lot of studies on 5G and how it's affecting a lot of different stuff, right? The thing that I look through PubMed and use consensus, I found this article. The article is titled Exposure to Extremely Low Frequency Magnetic Field and Childhood Cancer, a Systematic Review and Meta-Analysis. This is going to look at a lot of stuff. This is from 2021. The amount of, so it looked at 30 studies with overall participants of 186,000 and change. So a decent size, right? And then I don't have the breakdown of what those 33 studies were, right? Or RCTs and things like that. But the thing that I found interesting was, and I did some, I was in here looking like I was, what's the movie with Russell Crowe, The Beautiful Mind? I just needed a glass window to write the equations out on, because I'm trying to find the amounts here. But it was looking at the amount of, or not the amount, the strength of a magnetic field of the ultra low EMF was 0.4 microteslas. Look at this. If it was 0.4, it had a range. It was 0.4 to 0.7 or something. Let's get to the bottom here. I'll make sure I'm not.
You're saying what the devices were, or what it was?
The amount. Oh, here.
So children study. Yeah.
Yeah. So children exposed, and I don't know what the devices were, because again, it's looking at 33 studies and you're doing a meta-analysis of this and a review. So and you had a little bit of a range. So 0.2, 0.3, and 0.4 microteslas had 95% confidence interval. And then it's going through those, respective 0.2, 0.3, 95, and 95% confidence interval of 1.26, 1.49, and then 1.72, again, respective, times higher odds of childhood leukemia. In childhood brain tumors, children exposed to 0.2 microteslas had a 0.95, 95% confidence interval, higher times odds. Then I had to think about, because if you look at like AirPod, it's not a microteslas, it's in gigahertz. And it was 4 gigahertz, right? It was a AirPod around there. Because AirPods get talked about all the time. It's like, is it frying your brain or what's it doing? So then the conversion, which I'm not, I guess, what would that be? Like physics? I don't know even what field you're in, you're doing that conversion. So microteslas, 2 gigahertz, we kind of broke it down because you're looking at strength versus like hertz's cycle. So it's the frequency. And what we came up with was what?
7.
Yeah, it was 7 or 0.7 or, yeah. It was either 0.4 gigahertz or 4 gigahertz, but whatever we came up with, it was either 7 or 0.7. It was higher than what the study looked at coming from AirPods. And everybody, if you go on the internet, half the people are saying you're going to fry your brain. Half the people are like, oh, those people are crunchy hippies. Huge meta-analysis showing that there is a link to this. Now, if my conversion was correct, I don't know if I saved that math that we were doing. And that was with a little bit of help of AI, but I just thought it was interesting. And then you look at like wired headphones, there's still a little bit. And then they have air tube headphones that supposedly, I don't know, have less of the wiring closer up your head. I'm going that crazy with it. But what it made me think about was the amount of EMF like off of AirPods is like less than your iPad though. So I saw this on some crazy Instagram thing. If you go into your phone under general settings and then disclaimers, I mean, there's a thing that says don't hold the phone to your head, which is cool because that's how the phone is designed to be used. And it says use a wireless device or something like that. So then the wireless device everybody's using now is AirPods. So it was just an interesting thing that there's a disclaimer in your iPhone. If you didn't know that, that's legit, says don't use it next to your head. There's a huge systematic review or meta-analysis that says like it's linked to childhood leukemia. And why they went after children, I don't know. I'd have to see if there's an adult study on, effects of brain tumors and stuff like that.
I wonder if, I don't know.
And the exposure
as the-
load has to be low because it's a kid. I mean, if you're an adult, and I know this stuff hasn't been around that long,
Yeah.
but if you do it for 20 years versus 5.
Well, but I would venture to say that kids have them in a lot longer than adults do. Like,
Nowadays,
depending on the
yeah.
cutoff of when as an adult, when as a kid. But like the kids that come in here, they have them, they're just sitting there. Like they're not
All the
necessarily
time.
listening to anything, but they're in there. And they may be listening to something, but that's been a lot different. I feel
And
like.
I'm sure there's hearing issues just having that alone. I don't know. It's an interesting thing because, again, if I put a post out on Instagram about that right now, I would get destroyed by people about, oh, you don't know what you're talking about. Especially if you went off the micro tests, like it's magnetic field strength that has nothing to do with the gigahertz cycle. And that's why I was trying to make a conversion and see, and it was higher. I just thought it was interesting. If you have the option, don't put it up to your head. I mean, that's on the iPhone. Second, is a wired headphone better than an AirPod? I still use AirPods. I mean, I've gotten in the habit of running with them. I mean, it's a hard thing to go back to a wired bouncing around headphone thing, which I used to have to do before those existed. So I don't know. Am I still going to use it? Yeah, you'd have to prove to me. It's just like, do I still drink booze? And there's a lot of studies, and maybe they're going to put a carcinogenic label on all booze like this on cigarettes. We all have choices to make, but you can't trust somebody that doesn't have a vice. So I guess mine's wearing AirPods and drinking a glass of wine at the same time might go out
while
that way.
running.
I'm picturing that guy that does the sprint videos wearing different shoes and stuff. I'm
holding the 140-pound dumbbells.
Yeah. So one crunchy hippie topic and one kind of just maybe rethinking protein intake. But the protein intake thing they did talk about, and he was like the lower end threshold, because you get talked about that it's 2 grams of protein per kilogram or something. He's like the 1.2 is the gold standard still. Like if you get, because then there's thoughts that like too much, you do get a little bit of an insulin response to protein and all that stuff. I'm not here to argue about that.
I've always wondered about that with people who are obviously over a normal body weight. Like if somebody came in that was 275 pounds, are they going to be eating 275 grams or more of protein?
It's per body mass. Yeah. So you'd have to like literally have a DEXA scan to figure out what you're actually doing. So yeah, if we do body weight, because that's what when they were doing the calculations, Keith Barr did the calculation on Tim Ferriss' podcast, because he's the guy that basically discovered PGC1 alpha and that mechanism, and then mTOR. And they were talking about how different protein intakes, like whey protein versus like something else, affects those pathways differently. And then they asked about that, and he goes, the 1.2 kilograms or grams per kilogram lean body mass, and they used 100-pound conversion. And they said a protein bar typically has 20 grams of protein in it, because if you broke down 100-pound or 165-pound human, you could eat a bar, and if you ate 4 or 5 of those, that would give you enough throughout the day based on that equation. That's why most manufacturers try to get 20 grams in a bar, because he's like, it's just a breakdown factor. So it was like 4 or 5 of those bars if you weighed 100, which is in the study, that's the average American weight, which is maybe if you put men and women, but I bet that's still higher now.
Yeah. Well, but even if they were heavier, that lean mass would probably be close to the same.
Yeah, true.
If you had more fat mass.
Yeah,
it might be close to the 165. Yeah.
But the question is, are most people hitting that by default of not focusing on it, or are they going over? I mean, I think so. Again, 20 grams of protein is like a piece of meat the size of your fist is like the gold standard. Yeah. Now, if you have a giant fist or small one, obviously that changes. But so 20 grams to think that's protein. Now there's proteins in, legumes and nuts and, supplements and shakes and, different stuff like that, obviously. So I don't know. I kind of thought about it when they said it, like the 20 grams per bar. I was like, I bet I get more than that in a day.
Yeah, I think we do.
Yeah.
I think most people, like,
with a bunch of processed food. And,
I mean, I think a lot of people probably don't have as big of a breakfast as we do. If they eat anything, it probably doesn't have any protein in it. Lunch might be more protein. Dinner probably has the most.
The other one is this also looking at people who are not exercising.
Which one?
Like protein intake.
Yeah.
Like if you're exercising pretty hard, like
I think that's where the 2 grams comes in.
Yeah, might be.
And I think that's where that comes from, is like if you're and it's a lot of that's going to come down to basal metabolic rate. I mean, you have to figure in like what you're actually using calorically, which then breaks down back into macros. And that's where Walter Longo was talking about, is like if we break down the macros, then it's still, if you just crushed, so say you just did a certain type of protein shake and you're like, I'm going to do 3 of those today to make up. He's like, he was also saying it's not just not that it's the most beneficial, it could be deleterious. Because again, if you overload the system with any one amino acid more than the others, like you kind of start, he's like, everything's signaling molecules. And he goes, certain things are going to create more of an inflammatory reaction and things like, so it's, again, that gets way in the weeds. You lose the practicality. And he goes, yeah, just most people just need to eat maybe not less protein, but more variety of foods that have protein in it.
He was adding our beef and potatoes.
Eggs.
And eggs.
And shake.
I've started doing chicken during the week too.
Yeah.
I did for a while there, and then it started taking longer.
Yeah, it takes longer and it doesn't taste as good. It's lower in.
You guys need. You can throw 3 or 4 frozen chicken breasts or a bunch of chicken thighs in there. 10 minutes later, it's done. Frozen.
Oh, what?
Yeah. It's a pressure cooker, man.
Love some high pressure.
Yeah. And ours is an air fryer. Yeah. I know what I'm getting you guys for Christmas.
We got a cast iron skillet now. So we don't have a grill, but we are going to start using that for steaks.
Yeah.
I cooked the first steaks of the batch, and that's when I got the
the Omaha steaks. Oh yeah.
No, sorry.
From
the cow.
Yeah, we split a cow. Sadly, it was butchered terribly, in my opinion. So the steaks were.
Our steaks are good.
Yeah, I'm not saying the taste bad. Just the cuts were a little thin, and a lot of silver skin or fascia or whatever on a lot of them. That I was like, what are we doing? But anyways, let's get into cases. So we're trying again. More surface level, interesting things, like things that we think people would like to hear about, or that we're like, man, it just kind of blew my mind. So you're up first.
Yeah. I had a 49-year-old female runner, has had several episodic flares of discogenic low back pain, was seeing me during one of those flares. These all kind of started end of last year. And she runs 3 to 5 miles, 3 to 4 times a week, but is more so just scared at this point that running is causing her problems when she doesn't have pain running. But it just happened to start around the time that she would be running. So the long story short of that, I've seen her 5 times. She's running, doing some run walk combos, mostly doesn't have any pain when she's running. But she said, I know this is kind of a silly goal, but I've never been able to touch my toes. And because
how old is she?
She's 49. We were doing the top tier SFMA, and she did the multi-segmental flexion. She goes, okay, and I don't laugh. I can't touch my toes. I said, oh, okay, that's fine. I mean, people don't touch their toes all the time. She said, yeah, I've just never been able to, and I really want to. I said, okay, I bet we can figure out how you can touch your toes. She didn't have a lot of nerve tension, so I was like, that's not really, I don't think that's limiting it too much. She did have pain with SLR, a banana SLR closing that side down. But then when I watched her doing toe touch, low back, super flat, doesn't go into any flexion, and then she has the passive range of motion in her posterior chain to touch her toes. So once we got her desensitized to flexion, because at that point when I first started seeing her, she was flexion intolerant. But when that cleared up and she still couldn't touch her toes, I was like, hey, we're gonna flex your low back, and not repeatedly in flexions. We did it in a 6 months to 3 months supine for motor control, and then also flipped over into like a cat-cow and had her move her low back into flexion extension. And she touched her toes and she was like, no way, it's crazy. But proving to people, oh, hey, you didn't have to go stretch your hamstrings a bunch to get the result that you wanted, because it wouldn't have. You have plenty of flexibility in your hamstrings to be able to do that. So
I mean, this is a bold say. I don't think anybody has tight hamstrings.
Yeah.
I think you have extreme nerve tension. We got a couple of patients who got that. I think I have a guy that works at a spice factory. Or you have a legit like centralized motor control issue, or probably a little bit of both. And then it's like chicken or egg, like which one happened first? You're slamming into your nerves because your motor control won't let you get there, or you had pain and you start shutting down a pattern for a while. I just don't, if you think about like how tissues would remodel, I cannot remember the study, but they did a twin study. It was like out of the Soviet Union or something, where they basically like had a kid in a box, right? For developmental stuff. And then they looked at it from central nervous system development, speech, but they looked at like, movement and joint. So joints weren't, I wish I'll have to find the study. Joints didn't form the same, obviously, if you're not moving. We know developmental kinesiology, how that's working, but also like tissue will shorten and change, and you can get true like, strictures and contractures and stuff like that. But also I think they saw that it changed right back as soon as the person started moving. So my thing is, if somebody can only raise their leg 45 degrees before laying on their back, and I've never been able to touch my toes, like what position were you in for 3 years straight that your hamstring was that short? You'd have to be in a back bend, like laying on your stomach with your heels touching your head with your hamstring, like, you know what I mean? It just doesn't make sense.
Yeah.
And I know people out there might disagree with me. Can people have tight tissues? Yeah, I think there's phenotypical differences, but yeah, I don't know. I just think it's a combo of motor control, nerve sensitization, peripheral and central, and then, nerve pathoneurodynamics.
Because the other thing that kind of like, we talk about, sitting all the time, like my hamstrings get super tight from sitting. Then it's like most people probably are propping their legs up at night, right? So if they're sitting in a chair and legs are like straight out, I mean, they're sitting at almost like 90 degrees of hip flexion, just like with their legs propped up. You can do that all day, but yet also
sitting, the only portion of your hamstring that's not extended is like the bottom.
But that's almost like, I mean, most people are going to be sitting at almost like 90 degrees of hip flexion there. But then like you go to do it on the table and it's like, yeah, I can't get there. It's like, why? Like, how can you sit here for like 3 hours just fine? But then you go to actually touch your toes and you're like, yeah, I'm nowhere near.
I think it's a lot of central sensitivity, especially when somebody you see their low back, like it's not flexing or something, and then it does. Yeah. But I know somebody will jump on here and be like, yeah, I know tissue, it's fascia, whatever. But I'm not saying I'm right. That's just my opinion, but whatever. That on that one. What do you got?
I know you asked us for some fun cases.
Room 4, baby.
I don't know. It's not that I haven't had like anything like super interesting. Well, I guess I really haven't had anything that's like interesting at all. I guess we can talk a little bit about my patient that me and you talked about. I've only seen him one time. Yeah. Funny enough, he's not coming back because he found a provider that's in network. But hey, it is what it is. I saw him Tuesday, but he came in because he was diagnosed with brachioradial pruritus, which is just like itching of your forearm, right? I mean, that's basically what he was diagnosed with. He started having this around a year ago, had gone and seen a buddy of his that was a dermatologist. They gave him some like topical cream that's supposed to help relieve itching. He did that for like 3 or 4 months, which did nothing. And then eventually he got to the point where he was like, all right, he goes, I don't think this is actually working. And the dermatologist looked at him, he goes, I think you're right. It is what it is. Like for you to walk in and tell the provider that they're wrong, and the provider would be like, yeah, I think you're right. Like, it's pretty crazy. Got sent to an ortho. An ortho prescribed him, I think, meloxicam for the last like 4 months. And he's like, that didn't really do anything either.
Why would anybody take anything for 4 months that's not meant to be? You know what I mean? I don't know.
Because he said he eventually had to get to the point where he could like sleep, and he's like, it was waking me up at like 1 a.m. And then he'd like put ice packs on his arm. That would help. And then he would be able to like fall back asleep, I guess, after having the ice packs on his arm to like calm it down. So that's why I guess he was like, I need anything to be able to sleep. Let's see, a month ago, I think he went to his ortho, or 3 weeks ago. I don't know. He had a long intake. Got a steroid injection in his neck, which he said that helped like 90% of the itching and like the burning he kind of gets in his arms. He was like, it's 80% in my left arm, like 20% of the time it's in my right. But he goes, I don't really have to do a whole lot to my right arm. He goes, that kind of goes away on its own. The left one is the one that like, when it starts, it comes on like 5 o'clock at night, will last maybe like 2 hours. I can go to bed, then I have to wake up, put ice packs on my arm. I can fall back asleep, and then that's how the cycle kind of starts every day. So yeah, like, I mean, obviously he didn't have anything in his arm because it wasn't 5 p.m. at night. When he came into the office, it was 10 a.m. So he's like bright-eyed and bushy-tailed. So yeah, I guess like we had kind of talked like you couldn't reproduce anything mechanically, right? But if you look at the brachioradial pruritus, like just some common causes just of like a simple like Google, you got like cervical radiculopathy. You can have some like nerve root irritation. You could have a disc protrusion or a disc bulge, disc herniation. But like he doesn't have any of those. To me, didn't have any of those findings because I couldn't reproduce it except a little bit of neck pain and some like max foraminal compression. That's about all I could get, and it was on the left side. Then he's also got a left shoulder that has been bothering him for like years. Can't really play pickleball hardly anymore. I don't know. That's kind of a long ramble. I went after like cervical retractions for him to see if I could manipulate anything like in his neck, right? Because he had an injection done to his neck, which helped. So my goal was like, well, if I do something to your neck, does it make it better? Kind of like better, same, or worse, since I couldn't reproduce it in office. But then he also got a ton of relief in his shoulder from like some shoulder extensions, because that was like a huge limiter for him. But you had brought up the like potential like shingles stuff.
Well, something like shingles
or some type of like dormant virus,
all sorts of stuff.
So my question is like, talk a little bit about that, of like why you would.
Yeah, just I would vehemently disagree if you Google, pruritus of a nerve tract that it has anything to do with mechanics. We talked about the mechanics can perturb like dormant virus in a ganglion, or you have degenerative change, so you have an inflammatory cascade, and then that's going to kick off. That's shingles comes on from stress, right? Usually that's what we think is, or another viral load, or you were sick or something. So if somebody has bilateral symptoms, they got relief from a steroid injection where the meloxicam and muscle relaxation stuff was not really touching it. Steroid was like 90% effective, and it was a general, or it was in their neck, but it wasn't like we were doing a facet block. Yeah, I would just disagree that has anything to do with like trauma. And then it's like, well, when do you get like pruritus or itching of a nerve? Would be on the back end of an actual nerve injury, right? Like a nerve can get very itchy if you had, somebody that's had like true sciatica and they had like a traction injury or, something. I mean, they will literally say like, it feels numb, but it's also like, not like poison ivy itch, but you're just like, it's irritated. And that's, thought to be because you're remyelinating it. So you're kind of going through like a whole new, sensory processing. My thing would be, I think you're having some sort of viral load around that area, like some sort of ganglionic thing, which, the typical one is like herpes zoster and things like that. But if you look up, so I just looked up itching in a nerve. So I Googled that. It said, which is funny, itching in a nerve can be a symptom of neuropathic itch. Oh, thanks for that. Which is caused by damage to the nerves that sense itch. Great Google response. It can feel like prickling or crawling under the skin, which I would disagree with that, because that sounds like paresthesia. And that's where and that's what's hard with nerve stuff. Nerve stuff's not going to change in office most of the time, because when a nerve actually has Wallerian degeneration or something going on, like you're not going to back symptoms down. Pain is probably, if pain's present and it changes, like you can almost like rule out like legitimate radiculopathy. Because if you have, we talked about this before, it takes 12 to 24 hours of, constant or semi-constant pressure on a nerve to create Wallerian degeneration. That's not going to change. Like that takes time to come back. If you can change it, you have a reducible mechanical issue, right? Or a non-histochemical issue, or you don't have a nerve issue altogether. So that's what we were talking. I was like, and then it goes down into causes just on a Google search, and it says central and peripheral nervous system disorder. That's a good one. And then it goes right to metabolic, neurodegenerative, orthopedic, infectious, autoimmune, malignant, iatrogenic conditions, without saying medications. So as soon as I hear somebody say bilateral, it's itching, it's like worse at night, ice packs help in the steroid pack, we would still do mechanical stuff, but it'd be like, that steroid's the key there, in my opinion, bud. And like, could we change your diet, or could you go get another steroid pack and see if it completely goes away? Same stuff they do. Like our office manager here had shingles terribly, and she had to do topical stuff for the symptoms just because it's so painful. Topical stuff for the skin deterioration and damage. But then it was a lot of like anti-inflammatories and steroids and things like that to reduce the inflammatory effect. So the tough thing is, what is that guy actually feeling? Is it paresthesia? Is it itching? Is like, people feel different stuff. They explain it different ways. And that's where it probably gets a little bit tough. But I think the key is it's both sides. It doesn't sound like true paresthesia or radicular symptoms, and a steroid and ice helps. Again, ice on a neuropathic issue, I think we all know that ain't gonna do shit, right? So yeah, that'd be my thing. So again, I also think about people that I've seen where, I mean, I can't tell you how many times I've seen it now. Somebody comes in, they're like, I'm having like weird like stuff down this arm. And they're like, you know what? I'm also having weird stuff down this leg. And the first time I heard it, I was like, what the hell, man? That doesn't, like, what's going on? And then like, now I'm like, oh, I think you're having like a shingles reaction. That's like first, differential diagnosis thing. I'm like, oh, I think you're having a minor shingles, kind of thing. And like, I've seen it time and time, and even in like 30-year-olds, which you're not thinking that's a typical like age bracket. So it's just, I'm not saying that's what it is. I'm saying that it comes into my differential diagnosis when I see that presentation now. And that's not always pain. That's people being like, it's you know, it sounds like radicular symptoms. Yeah, it kind of hurts, but it's more like numb, tingly, weird. And then you're like, oh, okay. Or if they're saying, yeah, it's kind of like my face and my arm. If it's on your left, make sure you rule some stuff out. But yeah, so I'm just always thinking about like some sort of autoimmune or like, you know, underlying viral load or something like dormant virus. Yeah.
Are you still thinking about that even as someone who hasn't had chickenpox?
Yeah. So the whole thing is with chickenpox. So they've, you know, the herpes zoster virus doesn't have to come from chickenpox. You could also have herpes, right? So you're still going to wall off. There's numerous ganglionic viruses or that can be dormant in the system too. But then some people got the chickenpox vaccine and they'll never have chickenpox, but then they're still going to have a dormant virus in the ganglia on them. It's how that, you know, vaccine works. So you need to ask all those questions. But if you ask the question of, did you have chickenpox? And they say no, and you're like, oh, it can't be that. Like, it for sure could, especially with people that had the vaccine. I mean, there are numerous people that have had the vaccine, that can still have that. Yeah, it's an interesting one. Yeah, I wish we could see him again so we could, you know, do something, but I don't know, or talk about it more. My interesting cases, and we're about out of time. I say cases because I've just, in the past, the day that I got sick, and then yesterday, I've seen 2 TMJ cases where people are saying they've had jaw pain, and then they got night guards, night splints. And then after they got the night splints is when symptoms really cranked up. So they were already having like TMJ stuff and that sent them in there, but then it all got worse or changed. The reason I'm bringing this up is not what I did specifically for each person. It's actually how similar all this stuff is. So I'm still so glad that I took Brett Winchester's TMJ course, because he breaks down that course that TMJ dysfunction is one of the few things that he's like, I think there is literally a cookbook approach to it. And not that like it's the same for everybody, but you better go through this checklist of like order of operations, or you're probably not going to hit it, but it's also pretty easy to, you know, kind of assess and treat. And like, it is true, because both of these people, over 6 months of complaints, one is weird because it's like nervy. Like when they use a makeup brush is when they feel the most like, you know, paresthesia or whatever. It's not a lot of pain, but they have clicking, popping, lack of opening. The other one has legit pain at full opening. Both had a lack of opening. Both of the openings changed in visit. So they moved to this like amount of jaw opening improves, and clicking diminishes, pain goes down tremendously. It's just really easy. So I put that out there of, if you can take his course, take it. If you're afraid of treating TMJ and you're lost, you need to take it, because it's like, I knew a lot of what he taught. I just didn't quite know how he flowed through it and approached it. Or if you're a patient listening to this and you're going to all these different people and they're treating your TMJ and it's been 6, 8, 10 visits, like you should know within 2 visits of working with somebody with TMJ, if like you're going to help them, B, you need adjunctive care of like a night splint or some other, you know, bracing device or something else, or you should refer them out. Like it's one of those that it's just pretty clear cut. Like, so if you've been having prolonged care or you haven't, you know, don't know where to go, like find somebody that knows what they're doing. But it's one of those areas where it's like the Wild West, because both these people got prescribed night splints by their dentist. And if you look at their dentist website, they don't specialize in TMJ or TMD. And then I asked the questions like, well, is it a hard bite guard? Is it soft? Because again, if you have a soft night guard, you're basically just like chewing on a mouth guard you'd wear in football. Like I can promise you it's not doing anything to change your bite, to help with like, you know, mechanoreception and feedback or whatever. And then there's so much we don't understand in terms of like, why do people grind and clinch and all that in the first place, which most of these people do. So yeah, find somebody that's good. If you're a practitioner, take Brett's course if you feel like you need a little bit of help. And then if you're a patient and you've been told a lot of stuff and just stuff's not working, like it's pretty clear cut. That doesn't make it easy, but like you should be able to determine really fast, like what I guess the point of triage is for these people. Yeah, I think that's it. Anything else? The music in our office just turned on. It's like our cue to wrap up. So week in review 42. If you have any questions about any of this stuff, put it, I don't know where you're supposed to put it. You comment on a podcast. I don't know. Put it someplace. Leave us a review. Subscribe. I could say bend over and I'll show you. But yeah, and we'll see you next time.